Sandoval's diverse background includes work in both inpatient and outpatient setting and covers acute rehabilitation as well as comprehensive care units. He served as co-director of multiple sclerosis comprehensive care at Eastern Maine Medical Center, a comprehensive coordinated MS care program in collaboration with the National Multiple Sclerosis Society. In addition to working with patients with multiple sclerosis, Dr. Sandoval helps those with a variety of neurological disorders. He provides general rehabilitation and spasticity management to patients who have experienced stroke, traumatic brain injury, or spinal cord injury. Dr. Sandoval also works with adults with cerebral palsy, muscular dystrophy, and other muscle tone and movement disorders. Dear Professor Sandoval, it's our pleasure to have you as a speaker today, and the floor is yours. You have the word. Thank you so much.
Thank you so much. I will share the slides now. Let's see. Okay. Is it sharing the slide now? Can everybody see the slides?
Yeah, we can see it.
Okay. Yes, and everybody can hear me. So just interrupt me if for some reason you can't hear me or if the slides are not being shown.
Of course, may notice.
So thank you, everybody. Thank you for the opportunity to share our knowledge and experience in multiple sclerosis rehabilitation. I am one of the rehab doctors at the multiple sclerosis rehab program at Johns Hopkins University here in Baltimore. So today we're gonna, this evening, we're gonna talk about multiple sclerosis rehabilitation. I know there are other speakers who talked about more the neurologic and medical management, but tonight we will focus on the rehab management of MS. So these are my disclosures. I have no financial relationship with any of the products or medicines that we will discuss today. For the next 45 minutes, this is my outline. So we'll discuss the rehab approach to the management of multiple sclerosis or MS. I'll discuss the role of the physiatrist. So that is basically, I am a physiatrist, that's a physical medicine and rehab specialist. It may be called by other names in other countries. We'll discuss some of the most important rehab issues in MS, and I'll focus on about the 4 very important ones that we often see in the rehab clinic. And then we'll close with a summary. And after that, I think we'll open the floor to your questions. So the rehab approach to the management of a patient with multiple sclerosis. So this is how we practice it, at least here in the United States. It's an interdisciplinary approach, and really it takes a village. So at the center of everything is the patient. In the way we practice rehab, it's really a team approach. The team leader is often the physical medicine and rehab doctor or the physiatrist. Often we have a rehab nurse. Now, the number of staff available depends on the center. Of course, in Johns Hopkins, we are so fortunate. We have a lot of specialists available. It may vary depending on the size of the clinic or the hospital. Often in our team, we have a physical therapist. We have an occupational therapist, a speech therapist, a psychologist, an orthotist or prosthetist, a social worker, and we may have a vocational rehab specialist, all working in tandem in order to provide the best holistic care for the individual with MS. So briefly, what is the role of the physiatrist or a physical medicine and rehab doctor? Again, it may be called other things in other countries. So the role of the physiatrist in the care of a patient with MS is to coordinate the medical treatments other than the disease-modifying therapies, which is often already taken care of by the neurologist, and also to coordinate the rehab interventions in order to establish and achieve realistic functional goals for the specific individual with MS. Now, the way we practice medicine, at least in our setting, does every single MS patient need to see the physiatrist? Well, the answer is no, not always necessary, but it's always very useful to have their input. But there are some cases where it's really important if you can get the physiatrist involved in the patient's care. For example, in a setting where you have a rapid or an acute worsening of functional limitations, it's good to get the input from the physiatrist. For example, if the patient has an acute relapse of MS, especially if they're having a hard time with recovery, it's good to have the physiatrist involved in the patient's care. On the other end of the spectrum of MS, if you have the chronic, severely debilitated MS patient with many impairments requiring many kinds of interventions, it's good to also involve the physiatrist. When you need advanced symptom management, when, for example, oral medications is not enough, if you need to have injection therapies or device therapies or bracing, and when you have other specialists involved, it's good to have the physiatrist on board. When you have complex functional issues on the part of the patient, something like difficulty walking, you'd be surprised, can be a very complex issue, because a problem with walking may not just need a physical therapist. You may need bracing, you may need medication, may need oral or injectable medications. And finally, especially in a case where you have complex psychosocial issues, it's also good to involve the physiatrist. Again, the way in our setting, for example, in the more severe end of the spectrum, when you have a debilitated patient, you may need to admit the patient into a subacute rehab hospital or a skilled nursing facility. Then it's good to involve the services of the physiatrist. So now let's look at the rehab issues in MS. As I'm sure other speakers have discussed already, the symptoms and signs of MS are vast, since MS can affect anything from the brain, the optic nerves, to the spine. You can expect any one or any combination of many of these problems in MS, and every single one of this is actually a rehab problem. It could be a problem with cognition or fatigue or depression. It could be a problem with vision, speech, or swallowing. It could be a problem with muscle weakness, spasms, difficulty walking. It could be pain and bowel and bladder dysfunction. So any and all of these problems can be a rehab issue, and we'll spend all night if we're going to talk about every single one of these problems. So for purposes of today's discussion, I've chosen just 4, and these are by no means the only problems that an MS patient will have, but these are very common reasons for referral to the rehab clinic in a patient with MS. And we'll go discuss each one in turn. So I'll start with the top, which is fatigue. So in the early 2000s, the National MS Society in the United States had a public relations campaign where they had a lot of posters that look like this, and basically they list the symptoms of MS, and is it MS? Fatigue. So in the old days, initially, fatigue was ignored as in the description of MS, but by the 1980s, fatigue was recognized as the most common symptom of MS. It's experienced by over 77% of individuals with MS. MS-related fatigue is usually described as a physical exhaustion that is unrelated to the amount of activity performed. Usually it's worse in the afternoon when it's hot and humid, and patients will complain of being exhausted even when they wake up, even if they've slept soundly the previous night. Now, the mechanism of MS fatigue is really poorly understood and described. So it seems to correlate with the cerebral axonal injury, but there is a poor relationship between the amount of fatigue and the amount of disease in the patient. They think the fatigue may be from the pro-inflammatory cytokines that are involved in the disease process. It could be from hormone and adrenergic changes. And it also could be that there needs to be more extensive cortical activity to compensate for neuronal loss. So in order for the patient to do the same amount of brain thinking, they have to use a lot more energy, hence more fatigue. Now, there are other secondary causes of fatigue that we see in a patient with MS. And in fact, I think the first thing that we should do if a patient with MS complains of fatigue is to look at other factors that we are able to control. So these are things that are often seen in a patient with MS that we have some ability to control. For example, many patients with MS will have some sleep problems. So if we can improve their sleep, we can improve, lessen their fatigue. They may be in pain, and if we can control their pain, they will have less fatigue. Depression is sometimes very difficult to differentiate from fatigue because they can really present almost the same way. So you have to, interview the patient and tease out that the problem is not depression rather than fatigue. Patients with MS may be immobilized, may have difficulty walking, may be bedbound. And when you're bedbound, you are more likely to be, fatigued even with just a small amount of activity. And finally, medication. So I think doctors are also a major cause of fatigue because we tend to prescribe a lot of medications, and sometimes we end up with polypharmacy on the part of the patient. So sometimes it's a balancing act because you're trying to treat, for example, pain, but we know all of the pain pills will cause some amount of drowsiness or weakness, hence more fatigue. So sometimes it's a balance between trying to treat the other symptoms of MS versus not making the patient too fatigued. Inevitably, the patient will come to the clinic and ask, well, can you just give me a pill for my fatigue? And traditionally, providers have given one or a combination of the medications that you see on the screen. So none of these medications are indicated or FDA approved for MS fatigue. Really, they're approved for other conditions such as like attention deficit disorder or obstructive sleep apnea. But nevertheless, we try them. So commonly we can try amantadine, modafinil, armodafinil, or methylphenidate. The names in parentheses are the brand names in the United States. They may be sold under different brand names in other places. But again, there have been small studies that looked at whether or not these were effective for MS fatigue. And again, very small studies and conflicting results oftentimes. Actually, last year, 2021, one of our Hopkins neurologists actually did a study. He did a randomized placebo-controlled crossover double-blind trial looking at the efficacy of amantadine, modafinil, and methylphenidate versus placebo in the treatment of MS fatigue. And what did they find? They found that there was no difference. There was no benefit between any of these drugs versus placebo. So, so the next time we try to use one of these drugs, we have to keep in mind that they may not be any better than placebo, but they come with their own side effects, which in the end may be worse than treating the fatigue. Therefore, we should try to practice non-medical treatment of fatigue. So these are the following: energy conservation techniques. And if you have an occupational therapist, they can help you with this. You can use cooling devices and treatments, and you have to improve sleep. So in terms of cooling devices, it can be very simple and cheap to very expensive. So for example, this is a cooling vest. So this is a simple device. It's just a vest with a slot where you can put an ice pack. And if the patient wears this, it will cool down his body temperature and it can improve his fatigue. You can also use air conditioners, cooling fans, cold drinks to lower the body temperature, and which helps with fatigue. And the third thing that we mentioned is sleep. So sleep will definitely help with fatigue. In rehab, in neuro rehab, we believe in the concept of neuroplasticity. That's why we do rehab for MS, we do rehab for strokes, because of the concept of neuroplasticity. So it is a type of learning wherein the brain lays down new memory traces by activating new and undamaged neural pathways. Again, we use this in MS, in strokes, and this requires sleep. So in persons with MS, they need adequate sleep to maximize their compensatory neuroplasticity. And during much of sleep, cortical neurons undergo slow oscillation in membrane potentials, and this appears necessary for the offline processing required for new synaptic plasticity. Therefore, new learning requires fairly immediate sleep to sort of encode the new learned experiences. So it's not enough to retrain them to do physical therapy. They need like sleep to encode these new learning concepts. So after I've studied this and read this, so now I understand that you need sleep to learn new things. So now when I give a lecture and I open the lights in the lecture hall, I see the students. So I don't get offended anymore. They're not sleeping. They're actually learning through neuroplasticity, because sleep is important to learn new things. So sleep is important for everybody. So the next issue that we often see in the clinic is pain and pain in MS. So again, pain, is it MS? So it is a very common symptom in MS. At least half of patients with MS will experience some degree of pain during the disease course. And in up to 20%, it would be the presenting symptom to the clinic. So this is a study that looked at a large community sample of persons with MS in 2003. And in their survey, they found that the average pain that the MS individual experienced was 5.2 out of 10. So in a scale of 0 to 10, 0, no pain, 10 is the worst pain. They're at least moderate pain. But in 27%, they graded as a severe pain. And in 20%, the pain interfered with their activities of daily living, or ADL. So it prevented them from doing what they needed to do in their life. So I find that the best way to address and manage pain in MS is to try and break it down and see what kind of pain are we dealing with. So this is sort of a simplified list. I'm sure there are more detailed lists, but I think you can break down the types of pain in MS to the following 4. So it's a neuropathic type of pain, a musculoskeletal type of pain, an inflammatory pain, or an upper motor neuron UMN loss type pain. And we'll go through each one. So the neuropathic type of pain, so they would describe this like a burning pain, like an electric pain, or a shooting pain. So these are the common examples that we see in MS. So it could be a trigeminal neuralgia on the face. It could be our Lhermitte's type of pain, where you flex the neck and you get a shooting pain down the spine. It could be like a transverse myelitis type of pain, where there's a sensory level where the lesion is, and below that level you have this strange sensation of dysesthesia or pain. It sort of mixes with the next one, which is a chronic dysesthetic pain. So it could be a one extremity that sometimes they can't describe it as pain, but it's numb. It's sometimes poorly defined pain. And the last one is a radicular pain, which is like a sharp pain that shoots down one arm or one leg. So that's how they would commonly describe their pain. So the treatment for this kind of pain would be the use of an anticonvulsant, such as gabapentin or pregabalin, or the use of a tricyclic antidepressant like nortriptyline or amitriptyline. The next type of common pain in MS is a musculoskeletal type of pain. So an individual with MS is not exempt from getting low back pain, neck pain, just like any one of us. In fact, they're probably more at risk, because if you've got weakness on one hip, you're over-relying on the other hip. So eventually you're going to have pain, arthritis on the other hip. So you would treat this much the same way as you would treat anyone with musculoskeletal pain. You can treat this with analgesics like acetaminophen or paracetamol. You can treat it with your NSAIDs like ibuprofen or naproxen. You can do injections like trigger point injections or knee or shoulder injections. You can prescribe orthosis like a knee brace, an ankle brace, and I think very important is to do physical therapy, involve physical therapy in the treatment of musculoskeletal pain. The third type of pain is the inflammatory type of pain. And the classic example is your optic neuritis, which would be a retroorbital eye pain. And the classic treatment for this would be corticosteroids. And the last in our list would be the upper motor neuron loss type of pain. Specifically, we talk about spasticity and muscle spasms, which leads us to our next big topic, and we will go in more detail in that list, is spasticity. So it's a major complaint in MS. So what is spasticity? So this is the definition of spasticity, and I will read it. It is a motor disorder characterized by a velocity-dependent increase in tonic stretch reflexes or muscle tone, with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex as one component of the upper motor neuron syndrome. So it's a mouthful. That's the textbook definition. But I think if you see this in the clinic, when you know it when you see it. So spasticity is typically described as a muscle stiffness, a tightening or spasm with associated involuntary jerking, pain, and weakness. So this is a study by the North American Research Committee on MS, NARCOMS, in 2004. They had a population of like over 21,000 MS patients. And in their survey, they found that up to 84% of individuals with MS will have some amount of spasticity. And in 1/3 of these, they need to eliminate or modify some of their ADLs. So spasticity can impair gait, it can impair your activities of daily living, and it can cause pain. So this is an example of a spastic big toe. So the toe is a striatal toe, it goes up. The patient can't really control that. It's spastic. It's often painful. It's hard to put this foot in a shoe, and it interferes when you try to walk. So when you evaluate a patient with spasticity, you should not only evaluate him at rest when he is like in bed or if he is in the chair, but really you should evaluate tone during functional activity. So make the patient stand, make him transfer, make him walk, because sometimes that's when you see the spasticity, and that's when you can appreciate how the spasticity gets in the way of what the patient wants to do. But we also have to be careful, because spasticity may also be beneficial to the patient. So for example, for a patient with spasticity and weakness of the lower extremities, like spastic paraplegia, it's the extensor spasticity of the lower extremities that may be allowing the patient to stand, to be able to pivot, and to transfer, and maybe to even take steps and do some walking. So in that case, the extensor spasticity of his legs is allowing him to be very functional. So that's a case where you have to be careful, because if you're very aggressive in your treatment of spasticity, you could take away too much spasticity, and you can convert a patient who can walk to a patient who cannot walk. So, and they don't like that. They unfriend you on Facebook when you do that. So you have to have a good reason to treat spasticity. So I've listed 4 good reasons to treat spasticity. So number 1, to improve function. So if by treating the spasticity, we're trying to decrease or remove spasticity, can the patient walk better? Can he transfer better? Second, to improve ease in care. So usually with the hips, in the pelvic area. So if you can decrease the spasticity, does it become easier for the patient or the caregiver or the nurses to be able to dress the patient, to clean the patient for hygiene? Third, to improve positioning. By treating the spasticity, by decreasing spasticity, do you allow the patient to sit on a wheelchair for positioning? So that's a good reason to treat spasticity. And finally, to reduce pain. So spasms, which accompany spasticity, can be very painful. If you can reduce that, you reduce pain, and that will be very beneficial to the patient. So there are many things that you can do to address and decrease spasticity, and I've listed them here, but the most important is the first. So whatever else you do, you must have a good daily stretching program. In the clinic, usually we try to start the patient, after you've done your stretching and exercises, you could start the patient on an oral medication. So the most common oral medications that we try for spasticity is baclofen or tizanidine. These are oral medications. However, they do have their limitations. So one of the main limitations to both is it can cause drowsiness. So many patients cannot go to a high dose because they just get too drowsy. They can't go to work, they can't drive, they can't stay awake. So if these are not tolerated or they're insufficient to control spasticity, then we go a little bit more aggressive. So the next two, phenol and Botox, are injection modalities. So you inject the muscle, again, a little bit more invasive. And the last would be to try to use an intrathecal baclofen pump, which is an implantable pump to control spasticity. And I would like to spend just a little bit more time on the last two modalities, since we do practice these in our clinic in Hopkins. So botulinum toxin. So botulinum toxin is a neurotoxin, and in rehab, we use it to treat focal limb spasticity. So Botox is good if you have a few muscles, specific muscles that you want to target, such that if you decrease the spasticity in these few muscles, you can improve the function of the patient. So these are intramuscular injections. Usually we employ a guidance system. So either we use electrical stimulation guidance, or we use an EMG guidance to guide the needle to the muscle that we want to hit. The effect of Botox to relax a muscle lasts about 3 months. So if the patient likes the effect that he gets or she gets, then she has to come back to clinic every 3 months for the repeat injection. So in the next slide, I will just show a video of how we administer Botox. So this is done in the clinic. The patient is awake, and the most that we use is a cold spray to numb the skin where the needle will go. And again, in the video, we will see that the doctor will use an electrical stimulator / EMG machine to guide the needle. So the patient is just seated in the clinic, he's awake, and they're just cleaning the skin with alcohol. So this is the electrode that's connected to an electrical stimulator / EMG device. It can do both. That's the cold spray to numb the skin. So she turns on her EMG guidance, and it guides the needle, tells her where the spastic spot is. So you inject the needle, it's an intramuscular injection, you deliver the Botox, and she's done. So that's one spot that she injected. So depending on the amount of spasticity that you're trying to control, or the functional outcome that you want to get out of the injection, you may need to inject several muscles, and you may need to inject several sites on a big muscle, like a rectus femoris. You might need to inject several sites on a big muscle. There is a limit to how many injections and how much Botox you can give at any one time, and we can discuss it in the open question and answer if you're more interested. So you have to be focused on where you want to put the Botox, because you can't inject every single muscle in a spastic body. So this is just an example of a spastic hand. So you can see that the hand is flexed at the wrist and it's fisted. It's a spastic and paralyzed hand. But the problem with these hands is that the fingernails can dig into the skin in the palm, which will cause a skin breakdown, will produce a pressure sore, and can get infected. So even though the patient cannot move the hand, you need to be able to relax the hand so that you can clean it. So in this case, they injected the muscles for the hand, and this is a good result. 1 month after the injection, it is now possible to passively open the hand. So again, for hygiene, to be able to clean the hand so it doesn't get infected and doesn't get pressure sores. There are patients that respond very well to Botox. However, if you have like soft tissue contractures in chronically paralyzed patients, it may not be so useful anymore. Now, if you have a lot of muscles that are spastic, for example, in a patient that has a severe spastic paraplegia, where everything below the waist is just spastic, and the legs are big muscles, there's not enough Botox that you can inject to do any functional improvement there. So that's why they came up with the baclofen pump. So instead of having the patient swallow an oral baclofen pill, so using the same chemical in liquid form, they have the pump. So the pump is it's a metal, it's the size and shape of a metal hockey puck, which has a reservoir that contains liquid baclofen. It also has a motor and a battery. And this has to be implanted in the patient. It's implanted on the anterior abdomen subcutaneously. So it's just under the skin. There is a catheter that comes out of the pump, and the catheter is threaded around the trunk and into the spinal canal. And the tip of the catheter is usually around the mid-thoracic level inside the spinal canal. So this is another view of the patient. So from the front of the patient, that's where the pump is implanted. It's subcutaneous. It's just under the skin. You can feel it. You can even see the outline of the pump. The catheter will snake around the trunk, go to the back, and then go up the spinal canal. And the tip of the catheter is around like mid to upper thoracic level inside the spinal canal. So the concept is that the pump, it pumps out a continuous stream of liquid baclofen through the catheter and into the spinal canal. So it will continuously bathe the spinal roots, spinal nerves with liquid baclofen. In this system, you need really, really small amount of baclofen because you're already sending it directly into the spinal canal. So it's a small amount of baclofen. It doesn't go through the systemic circulation, unlike when you swallow a baclofen pill, it has to go through the bloodstream, and that's where you get all your side effects of drowsiness, etc. Versus if it's sent directly intrathecally, there should be minimal to zero sedating side effects, and you need a small amount. In this way, you can actually achieve a greater effect on the especially lower extremity spasticity. The effect is better for the lower extremities compared to the upper extremities, just because of where by gravity it will bathe the spinal nerves to the lower extremities and not to the upper extremities. There is a risk if you try to put the catheter higher up, is that you might, if it's too high, like cervical area, people get scared because you might weaken the diaphragm because it's now you're involving the nerves to the cervical area, and obviously you don't want to weaken the diaphragm or else you might not be able to breathe. So the therapy is better for lower extremities than upper extremity spasticity. So we can look at an actual example. So this is a real patient. So there's an actual patient, a 53-year-old male. He has secondary progressive multiple sclerosis for the past 10 years. He has severe spastic lower extremities. He has a stiff and slow gait. He has been taking oral baclofen at 10 milligrams 3 times a day. However, this low dose is not effective, but he could not tolerate any higher dose because it would just make him drowsy all day. In this patient, they actually done 3 rounds of Botox, but again, they did not see much functional improvement. So that's why they thought of doing the intrathecal baclofen pump. So in the next slide, we'll see the patient before they implant the pump, and we can see how he walks before the pump.
Okay, walking good. Okay, you can turn around, it's all right. I'll get in front of you. Okay. Great, thank you.
So you can see he really has severe spasticity of the lower extremities. They're very stiff. It's hard for him to walk. He walks very slow. They've tried oral baclofen, but he can't tolerate the drowsiness. They've tried Botox. So the next step is to implant an intrathecal baclofen pump. So in the next slide, we see the patient, he's going to be 2 weeks post-implantation, and he will be in inpatient rehab units. So in our setting, we do have acute inpatient rehab units where we can admit the patient just for comprehensive high-intensity rehab. They get physical therapy every day or at least 5 days of the week. They get high-intensity physical therapy, occupational therapy, plus the physician can then make adjustments to the pump. And since the patient is in a monitored setting, we can monitor the side effects, we can monitor how he does with the pump. The pump can, the dose can be adjusted to go up, to go down, and we can see how his gait changes with the titration of the pump. So in the next slide, we will see the patient after the pump is implanted and compare his gait now.
All right, so this is Billy after getting the baclofen pump. He is at 125 micrograms a day.
You go to a room equal, you're actually here to get a little stronger.
This is without the ankle brace, which we were recommending on the left and the right, but not sure if he needs them anymore. Good.
Yeah.
See the improved knee flexion, improved heel strike. Good. Why don't you turn around and walk towards us?
Do you want to go get something to drink? Let's do that.
It's a great result. Excellent.
Oh, you don't need any money. We'll walk downstairs.
A little bit.
Get it together.
Yesterday we turned it up to 150 and made you feel a little weak, so we lowered it to 125 today. So Billy, tell me how the baclofen pump makes you feel.
More flexible, makes me feel like I have more control of my legs, and it just it's so much better than the oral baclofen, because the oral baclofen didn't do anything. This stuff is just, it's phenomenal. It makes everything loose.
Good.
So you can see the difference now that he has the pump and he's in rehab doing intensive physical therapy, and the physician who's narrating the description is able to adjust the pump up and down. If you heard him, he said that they actually went a little bit high and he felt too loose and weak, so they had to turn it back down, and you can do that with the pump. You can see that now that he's post-op, his legs are looser. In fact, he feels a little bit too loose. That's why he needs to use the canes, because before he would rely on the stiffness of his legs to walk. Now he's not, he feels a little bit uncertain because his legs are looser. But you can see that his gait is smoother and it's less laborious. He can move a little faster now that he has the pump. And again, you have with the pump, you can go up, you can go down, depending on how the patient feels with the titration of the pump. So that's the intrathecal baclofen pump for spasticity. And the fourth problem that we'll talk about with regards to rehab issues in MS, a very big issue, is gait impairment in MS. Up to 75% of persons with MS will have some form of gait impairment during the course of their condition. And there are many reasons, and it's usually a combination of reasons why they have problems with gait. So this will be because of weakness, proprioceptive loss, cerebellar or vestibular dysfunction, visual loss, the spasticity and contractures, which we already discussed, the fatigue, which we also discussed, plus the inability to multitask. Although we won't touch on this specifically, but cognitive issues do occur in patients with MS. And one of the things that happens is they cannot multitask. So if you've ever walked with a patient with MS, if you walk with the patient and you ask them a question, they will stop walking, look at you, answer your question, then carry on walking, because they cannot walk and talk at the same time. If they try to do that, they could trip and fall. So number one in our treatment will always be physical therapy. So always involve physical therapy in management of patient with gait impairment. Eventually, you may require the use of a gait-assistive device, which includes canes, crutches, walkers, such as this one. Very commonly seen in MS is the problem of a foot drop. So if we have a foot drop, then we usually prescribe an ankle foot orthosis. And this is one of the versions that we see. They can be made of plastic, they can be made of metal or carbon fiber. So traditionally, this is what we would prescribe for a patient with foot drop. But there are limitations with this device. Many patients don't like them. Why? They can be heavy. They're stiff, which is what they're supposed to do so that you don't drag the foot. But they can be hot if you have to wear this in the summer and you're sweating. And they don't really let the muscles or the joints move once they're inside the brace. Very often patients just leave them in the closet and never use them again. So they thought of, why don't we try using electrical stimulation to stimulate the foot to do a dorsiflexion moment so that it can not catch the floor when you walk. So they came up with the use of functional electrical stimulation in order to stimulate the foot to do a dorsiflexion during gait. So this is an early version of the device. So this is one of the brands that's on the market. It's called the Walk Aid, an early version of this electrical stimulation device. In the United States, there are two main brands that are on the market. One is the Walk Aid and one is the Bioness. They do basically the same thing and they almost look the same. These are older versions of the device. They look more sleeker now. And again, what it does, it is an electrical stimulator that is attached by a cuff on the patient, and it tries to stimulate the muscles of the leg to make the foot dorsiflex so that you can walk without catching your foot and without using an AFO. So on the next slide, we have a simulation of what this treatment looks like. So this is a patient with a left foot drop. So you can see he's dragging the foot. So if we review our neuroanatomy, it is the peroneal nerve that stimulates the tibialis anterior, which causes the foot to dorsiflex. So this is the Walk Aid. So it attaches to the proximal leg, and the electrode is right on top of the peroneal nerve. So you have to program the device so that it fires an electrical stimulus during swing phase, which makes the foot dorsiflex right at the right moment during swing phase so that you don't catch the foot and you are able to walk without the foot brace or the AFO. So again, they wanted to get rid of the AFO, and this is one solution to do that. So how is this in practice? So we can look at an actual patient. So this is a real patient, a 57-year-old female. She's had multiple sclerosis for 15 years. So she's quite affected. She has bilateral hip and knee weakness with bilateral foot drop. So the only way she can walk is she uses bilateral forearm crutches with bilateral knee, ankle, foot orthosis to walk. So she has a lot of equipment in order to walk. So we will see how she walks at baseline on the next slide.
All right, whenever you're ready. Yeah.
So you can see that her walking is quite labored. She has two crutches, two knee, ankle, foot orthoses, and it's a slow gait. So they took this patient and they trained her with the use of the Walk Aid. So she's going to use one Walk Aid on the right leg. So by doing that, she's able to get rid of the knee, ankle, foot orthosis on the right, and she's able to get rid of the cane or the crutch on the left. So she's cut down her devices by like half. So compare her gait on the next slide using the Walk Aid on the right leg. You can see that her walking is smoother, it's faster, it's less laborious, and she has gotten rid of the brace on the right leg. In fact, in this patient, she may benefit from bilateral devices so that maybe she can get rid of the brace on the left leg as well. And finally, one more thing that we can offer MS patients with gait impairment, one more thing. This is a pill. So this pill is dalfampridine. So the brand name in the United States is Ampera, which is dalfampridine, which is a 4-aminopyridine. So this is a pill. It is an extended release potassium channel blocker that enhances conduction in damaged nerves. In the pivotal trials, it showed that in about a third of patients with MS, it improves their walking speed significantly. So it is not perfect. So it has a significant benefit in a third of patients. So that means 2/3 it didn't really help much. But in about a third of MS patients, it will help improve their walking speed. It can improve other parameters, but in the studies, they really just look at walking speed. And when they recruited patients, they recruited patients with any kind of MS. It was relapsing remitting MS, secondary progressive MS, primary progressive MS. Overall, all of them, about a third improved. So there are some contraindications. In the studies, they show that there may be an increased risk of seizures with this medication. So if you have seizures, it's not a good drug to use. You also have to have a good kidney function when you use this medication. But those are the main concerns with the use of this medication. So how did they do the trials when they tested walking speed? So what they did is they used the 25-foot walk test. So how do they do that? So they asked the patient to walk down a corridor 25 feet. So walk as quickly as possible, but in a safe manner. So walk 25 feet. Now, if the patient already uses a cane or already uses a brace, they are allowed to use those devices. So they're asked to walk as fast as you can, safely, 25 feet. They do 2 trials and they get the average of the speed. So that's how fast you walk 25 feet. In a normal person, you should be able to walk 25 feet in about less than 6.5 seconds in 25 feet. So we're going to look at 2 actual patients. And these patients actually are among the 1/3 that benefited from dalfampridine. So in the first patient, this is a 42-year-old female. She's had MS for 14 years. NA means she's not working. She's not working right now. It took her 11.26 seconds to walk 25 feet. So it's about 2.2 feet per second. So on the next slide, we'll see how she walks before she took this medication. So at baseline, you can see that she walks rather slowly. The examiner is following her right behind her in case she falls. She has to touch the wall in order to not fall. So it took her about 11.2 seconds to walk 25 feet. So they tried her on dalfampridine, and the next slide shows how she walks after 12 weeks and compare the 2. So on the right side, this is her walk after 12 weeks of dalfampridine. She's cut her walking time down to 8.8 seconds from the original 11.2 seconds. So they do 2 trials, and you can see that she is consistent. She had about a 22% increase in her walking speed. Also, the quality is improved. She doesn't have to hold the wall in order to complete the walk. And finally, we have a second patient who also improved with dalfampridine. This is a secondary progressive patient, 58-year-old male, has had MS for 11 years. He still works. He's a lumber salesman. So it takes him 10.2 seconds to walk 25 feet, but he needs to use a cane. So look at his gait before they tried this medication. That's him. He needs to walk with a cane. Takes him 10.2 seconds to walk 25 feet. So they tried him on dalfampridine, and they did the test again after 6 weeks and compared the 2. On the far right, after 6 weeks of treatment, he cut his walking time down to 7.8 seconds from 10.2 seconds. So it's like a 28% improvement. They do 2 trials, and on the second trial, his improvement is still consistent. So again, the drug is not perfect. It works in about a third of MS patients, any kind of MS patient. But in those 1/3 that work, it really helps improve their gait in terms of speed, also in terms of quality. So again, so in summary, we spent the last 45 minutes discussing some of the important things about MS rehab. We talked about the rehab approach to the management of an individual with MS. We talked about the role of the physiatrist, the physical medicine rehab doctor, in the management of MS. We talked about the rehab issues in MS. There are many, but for today, we focused on the top 4 very important and commonly seen rehab issues in the clinic in terms of MS: fatigue, pain, spasticity, and gait. And we discussed the things in terms of medication, treatments, devices that rehab can offer to help deal with these rehab issues in MS. So these are my references for the talk. And with that, so this is my last slide. So in the United States, we have a nonprofit organization, the National Multiple Sclerosis Society. It's a US-wide organization that advocates for individuals with MS. They raise a lot of money through activities like the MS Walk. They raise money for research and also to help provide funds and devices for individuals with MS. This is the team that we have at Johns Hopkins. We had the walk in Baltimore. We had it every year except the 2 years during COVID. We had a virtual walk. But hopefully with less COVID, I think things are now going back to a real walk with real providers and patients and families with individuals with MS. So with that, I thank you for your attention. And I think we now have some time for your questions or comments. Thank you.
Thank you, Dr. Sandoval, for your excellent presentation. If you permit it, we can take some few questions.
Sure.
First one, he's a doctor asking about how can we differentiate spastic muscles from fibrotic ones?
Good. That's a good question. It's a very good, and sometimes it's not easy, not always easy. So if you go back to the definition of spasticity, it's supposed to be a velocity-dependent increase in tone. So I don't know if you can see me. So if it's really spastic, if you go slow, you may be able to move it. But if you jerk it, then it will catch. So it has to be velocity-dependent. That's the actual definition of spasticity. In mild cases, it may not look spastic if you go slow, but the moment you go increase velocity, it will catch you. So that is true spasticity. There are grades of spasticity, and we use what we call the modified Ashworth scale from 0 to 4. So 0 is normal without any spasticity. Then once you have a catch, 1, 2, 3. But when you get to 4, 4 is rigid, meaning it's so spastic that you can't really move it. Now, sometimes that's hard to distinguish from true fibrosis. So sometimes that's really difficult to determine from fibrosis. Sometimes by history, you know that this patient has not moved this arm for 5 years. That's probably fibrotic already. It hasn't moved for 5 years. But if it's a fresh patient, hasn't had MS for very long, it's probably still spasticity. Sometimes if you have access to an EMG and you stick a needle there, if you hear a lot of electrical activity, then that means the muscles are firing. So it's active. It's not fibrotic. Versus if it's just connective tissue, scarred, and you probably won't hear a lot of electrical activity with an EMG. But when you get to stage 4 of spasticity or grade 4 spasticity versus, sometimes it's hard to differentiate. Sometimes.
A second question is asking about when do you decide to use EMG guidance for buttocks injection?
And electrical stim?
Is it the same?
So the question was, when do you use EMG and when do you use electrical stim? Good question. So So I think one is in my practice, I tend to use electrical stim for smaller muscles. So for small muscles, you want to, you're more likely to not hit the right muscle. So like for let's say the flexors of the hand, all the flexors are very close to each other. The belly of the muscles are on your forearm. Do you want to hit just the superficial flexor term superficialis to one finger, to the other finger? If you want to be more precise, you can use the electrical stim. For large muscles, like you're not likely to miss, I tend to use the EMG guidance. So like a rectus femoral, you're not going to miss, but you want to make sure that you're in the muscle, not in the blood vessel, not in the bone or fat or other. So then the EMG tells you that you are in the muscle. Again, there are pros and cons. Yeah. The other thing is that EMG tells you the activity, so you can see or hear the noise or the electrical signal. So sometimes you think it's this muscle that I should inject, but no, it's silent. But you move the needle and it's that muscle that's the spastic muscle, because that's very noisy. That's what you should inject. So there are pros and cons with how you use it.
Okay. So the next question asking about baclofen, and they're asking, is there any possible addiction with baclofen pump and overuse?
Addiction with the pump?
Yeah.
Not really. And actually, even with the oral baclofen, I don't think I see any addictive problems with even the oral baclofen. I don't think it's addictive. It's actually there is less side effects. You don't really. I don't think there's any dependence or addiction with the pump. Your only concern would be if you think that the patient has a drug substance abuse problem, he may not be a good candidate for the pump, because if you're wise, you can actually inject other things into that pump. You can, because it is accessible subcutaneously. That's how you refill it. So if you think the patient will like inject a drug in his pump, then that's not the good patient.
Okay. The next question is from Dr. Shakir. He asking about how do you calculate the dose of Botox per muscle injected?
So good question. So the package insert of Botox, and there are many brands of the botulinum toxin now. I'm talking about the original brand, botulinum toxin. The package insert gives you a 400 units is the maximum dose that you should inject at any 3-month interval. So that's the most that you should. Some people go above that, and it is practiced. Although the label says you should be up to 400. Actually, if you read the package insert of the Botox product, they're very good. They tell you what is the good starting dose per specific muscle. So again, depending on the muscle, like a big muscle, like a gastrocnemius, you can start like anywhere from 50 to 100 units when you start the patient. Then you can always go higher. Again, the maximum would be 400 at any one time for anywhere you inject, 400 at any one time. But you start, I start low, go slow. So start, and smaller muscles will have a smaller starting dose. So like small hand muscles, you might need to start 20 units, again, and depending on how spastic the muscle is. But the Botox brand actually has a good package insert. It tells you what good starting and maximum like dosing is.
Okay, thank you. The next question is from Dr. Mozan Mohammed. He's asking about ataxia as a common sign in MS. He's asking, is there any medical treatment to see effective in ataxia?
So that is a good question, and unfortunately, the answer is very challenging. Usually, it's tremors in ataxia in MS are probably very difficult to manage. I've not really, honestly, had a good management with it's usually ataxia and tremor. Really, no good drug. They've tried drugs from other other conditions. They tried like propranolol, that doesn't really help much. Baclofen or any of the muscle relaxant doesn't really help much. I think in the literature, some people have tried isoniazid, but the Parkinson's drugs really are not that helpful. There are some small studies where they try deep brain stimulation. I've not had any patients go that far, but if you have access to a deep brain stimulation program, they might try. Otherwise, we just try some physical modalities, like you put weights on their walker, so they're not gonna lift their walker. You put weights on the walker. You can try putting weights on their hands or legs to try to weigh them down. Some try to maybe vests that are heavy, like a weighted vest, to bring them down. But unfortunately, it's very difficult, ataxia and tremors in MS.
Thank you. There's another question from Dr. Ann Borlin. Is action, are medications the same for spasticity and for speech slow? Are they the same, or there are differences between spasticity and speech slow?
Speech slowing?
Yeah.
So the speech slowing will depends on why is the speech like slowing. There is like spastic speech that can happen, and there are other reasons why you might have a slow speech. If the speech is like a spastic speech, so some thoughts. One is the oral baclofen may help, again, if it's a spastic cause of the speech, because it's systemic. The pump will not help because it's not going to reach your mouth. It can't reach the mouth. If it's some of our ENTs also use Botox. So if there's something spastic that they can inject with Botox, then they also use Botox. But that I refer to them. They can scope and see if there's something spastic in the esophagus or the mouth pathway.
Okay, there's a physician asking a new question. He's asking, are there any physical exercise recommendation or references for low DSS patient to preserve functional function and prevent worsening?
Do you recommend what? Can you repeat the question again?
Okay. Are there any physical exercising recommendation or references for low DSS patients to preserve functional function and prevent worsening?
For low, I didn't hear that. Low EDSS patients?
Yes, patients, yeah. Is there any physical exercising recommendation?
And what was the last part of the question? Low EDSS patients, and what was the last? To prevent
worsening. Okay.
So the question was, are there specific exercises for low EDSS?
Yes. Yeah.
Okay. So when you say low EDSS, that means actually good patient, right? Because the higher the EDSS is worse. So low EDSS are very functional. Actually, like somebody actually published a paper where they broke down the recommended activities per EDSS range. So for example, again, depend on EDS 1, 2, 3, 4 has almost no visible movement disability, really. So for those patients, there's almost no real limitation on what they can do. You just have to check the balance, right? Because like if their balance is bad, you don't want them to be doing anything, standing on one leg. But if for low EDSS patients, many of those actually can basically do almost the same exercises as a non-MS individual, right? So again, but just check that their vision is good and their balance is good. But if their balance is good, they can do any walking exercises and any strengthening exercises, as long as they're like low EDSS. Again, depends on the exact number. And I think as long as they can still tolerate a combination of, again, these are broad, sort of broad recommendations, because these are broad EDSS, combination of conditioning, aerobic exercises and strengthening exercises. So usually alternating days of some amount of aerobic exercise, some amount of strengthening exercises. aquatic therapy is good because you're not going to fall as long as you're not going to drown. You can swim, but you're not going to trip or fall if you're in the pool. So actually, aquatic is also, they like it for stretching and all that. That's to maintain physical function, joint mobility, and all that. But there's only so much that it can do to prevent progressive MS, right? So you still need your DMTs and all that, which will also help prevent disability progression. That's why you need the disease-modifying therapies. Was there a last part of the question? I don't know if I answered the last part of the question, or did I answer her question? Oh, I can't hear you. I think you're mute. Oh, I think you're on mute. I didn't hear your question.
You hear me now?
Ah, yes.
He's asking the same question: how to preserve function, how to prevent worsening in patients with low EDSS.
To prevent worsening, yes. So again, there's a limit to what physical therapy and exercise can do. You still need, the disease-modifying therapies are still important, right? Because they are still proven to prevent disease progression, especially in active MS. But again, in low EDSS, there's not so much limitation. Now, once you get higher, then you have more limit. If you need a cane to walk, then you may need to do exercises seated so that you don't fall, or somebody must be there with you if you're like on a treadmill or something. If like you have weakness on one leg, if you have weakness on one arm, you may need like a physical therapist or a trainer to work with you for safety.
Okay, thank you.
Mhm.
We have another question from Dr. Tomoko Arakaki. He's asking about the management of botulinum toxin in patients with spasticity and weakness at the same time, especially in the lower limb. How do you manage the use of botulinum toxin when you have spasticity and weakness at the same time in lower limb?
In the lower limb. So in the good question, in the lower limb, for example, in the lower limb, the foot drop is usually the problem. So usually the bad spasticity, the plantar flexion and inversion on the ankle. So that's why you get the foot. Not only do you have weakness of the dorsiflexion, but you have a lot of spasticity going down. So that's what you try to Botox. You Botox the gastrocnemius and also the tibialis posterior, because you're trying to get rid of the plantar flexion and inversion. Don't Botox the dorsiflexors because you want them to work. You want them to be free to go up. So hopefully when you can control the plantar flexion and inversion, you can actually put the foot better inside the AFO because they're fighting the AFO. So that's why you don't just treat spasticity. So you have to see, well, what are we trying to do? What are we trying to do? So you can see that. I've also had some patients where I had to give a little bit of Botox to the knee extensors because they tend to have a hyperextension. They like to do a recurvatum. So sometimes if you just Botox just a little bit on the knee extensor, just a little bit, not too much, so that you can try to avoid too much hyperextension. Again, you don't want to weaken too much. Sometimes you have to play and see how the patient works.
I have a question from Dr. Anne. She's asking, is cannabis good for spasticity besides pain? And what is your recommendation for cannabis for spasticity besides pain?
So that is controversial. That's a good question. That's a good question, and it's a controversial question. So the studies have been conflicting. For example, in spasticity, patients will report that their spasticity gets better with the cannabis. But when a physician tests the spasticity, they don't see a difference. So subjectively, they feel better in terms of spasticity with the cannabis. But objectively, if a second or third person tests the spasticity, they don't see a difference. So that's the answer to that. So it's sort of and again in the federal United States, it is not really allowed, but some individual U.S. states allow, but it's not like FDA sanctioned or approved. But in like Canada, they do use for spasticity and pain, not yet approved in the US for those indications. But the sort of the data is soft, whether it truly helps with spasticity or not. But I think the Sativex, which is available in Canada, they're actually trying to get it into the States. So they're doing trials to prove that it does improve like spasticity. Mm-hmm.
Another question about amantadine. They asking what is the doses of amantadine that you need to treat fatigue?
So it's about 100 twice a day is the usual dose of amantadine. Yeah, so like about 200, 100 twice a day. Sometimes it helps, sometimes it doesn't help. So I don't think it really hurts. It's a benign drug most of the time.
I think we have no more questions. That was the last one. Dr. Shahidi, do you see any question?
Yes. Excuse me. I see that Carlo Bronia is presented and okay, say thanks. Some questions to be discussed with you. Carlo Bronia.
So what was that again?
So I see that Dr. Carlo Bronia from Detroit. So asked you, so have you seen significant improvement over the long term in walking and legs functioning in MS patient treated aggressively after many years?
I didn't catch that. After, say it again.
So he is telling us that he is watching from Detroit, and they live in Fez in Morocco, but he just completed a 6-month lock-in in. So I told to us that he will therefore first let us know there were many patients that he saw who were very appreciative for your help. So
thank you.
In general, I'm an optimistic person, physician, and I would like your opinion on how optimistic you feel we should be when discussing the possibility of recovery of lower limb function mobility with patients. Dr. Given Giovanni from England seems to be very optimistic with patients regarding their chance for recovery of leg function working. He tells of seeing improvement in leg function after many years to reach 5 more years of sustained aggressive DMT. So for the question that he has, have you seen significant improvement, excuse me, over the long term in walking and leg function in MS patients treated aggressively after many years? The second question, are you encouraging patients in general, or is there a specific subgroup you feel more optimistic about? I'm generally not very optimistic with males who present with primarily is the second question that he has submitted.
I think the main idea is for patients, the recovery of lower limbs generally takes.
So we have difficulty to hear you, Professor
Yes.
I'm just trying to explain you the main idea of Dr. Bornia. What he said is that for people with MS, people with lower limb dysfunction takes more time to recover, about 3 to 5 years under aggressive DMT. This is modifying therapy. The question is, do you feel really optimistic about their recovery, and do you stay aggressive about the treatment, even if you don't see a recovery for 1 or 2 treatments?
Okay, I think I understand the question. So, so the question was, are you optimistic about
therapy for Do you maintain therapy for lower limb dysfunction?
Okay, so so some thoughts. So first is what we look at what kind of a situation is the MS patient. So for example, if it's a relapsing remitting MS patient with an acute flare, we expect that to more or less improve. We expect some improvement with like steroids and aggressive therapy. Younger patient, in that case, in most cases you want near return to normal. There could, again, just because of the natural history of MS, even with an acute relapse, you may not always go back to 100%. But in that population with aggressive like physical therapy, rehab, exercise, that kind of patient, I think you should be able to recover, near normal, if not normal. So that kind of patient, be aggressive, if especially if they're very active, they're still working, be aggressive. And that kind of patient we expect should recover. Younger patient, otherwise healthy patient should recover. Chronic patients. So again, if we have like secondary progressive or primary progressive MS, we also have to look at the natural course of the MS, and by definition, that secondary and primary progressive will progress. The DMTs are getting better, but they again also have a limitation on how much they can stop, slow down the progression. If I get that kind of patient that's been like MS for 10, 20 years, I think, I will be more like sort of realistic with what we can achieve. So if you've had MS for 20 years, we're not expecting you to turn the clock back 20 years. If you have some spasticity and other issues, pain that otherwise get in the way of your gait and walking, definitely that, try to get rid of all those things that get in your way: pain, spasticity, fatigue, musculoskeletal problems. So those definitely you can control. Stretching, muscle training, conditioning, that can improve. I think that I will have a more measured expectation of improvement. I will be very happy actually with maintenance also. So like if I see you now and if I follow you for the next 10 years, I want you at least not get worse than what we are right now. So I think another goal would be maintenance. Again, primary progressive and secondary progressive, by definition, they will progress. But I think we can slow it down. But I would, I also don't want to be unrealistic with the expectation. I would tell them, I think, I think we can, if I can identify a few things that I can control, spasticity, pain, contractures, we can improve that. And if it looks like the patient is just deconditioned, not enough stretching, we can improve that. We cannot, reverse if axons have been lost, won't necessarily reverse that. And then I want to maintain. So if I see like this, let's see what we can do to maintain for as long as possible. The Ampira is the only drug that we have so far that can give us, 20% better walking, again, in a third of patients. So I offer it to everybody, give it a trial, give it a month. If it works, it works. If it doesn't work, it doesn't work. Until we get like better interventions and better disease modifying therapies. Again, I would be realistic, but try to be also as positive as possible. You want to emphasize the positive, and you want to avoid falling. Anybody who falls, that's not good, because that sets you back. It can set you all the way back if you fall, break something. I don't know if I answered his question all the way, but that I think. But I would be realistic with the patient, and I don't want to promise something unrealistic. But see them regularly, follow them, regularly throughout their course, and then address what you can address.
Dr. Saidi, do you see any other question?
Yes, you have another question in experimental field. In an experimental animal model of MS, we have demonstrated that irradiation low dose could be benefic operates induced MS by MOG. The question is, what other parameters besides L and cytokine can we use it for other coming studies?
Can you? I didn't get the question. Can you repeat the question, please?
In an experimental model, in an experimental animal model of MS, we have demonstrated that a radiation low dose could be benefic of rats induced MS by MOG. The question is, what other parameters besides IL and cytokine can we use it for other coming studies?
For other animal studies, is that the question?
The question is, we have demonstrated that irradiation for lower dose irradiation had benefic effects.
We have difficulties to hear you, Dr. Benmoy.
You hear me, Professor Kanda?
Oh, that's better. Yes.
Yes, you can hear me now?
Yes.
Dr. Kadil is asking about the effect of lower dose irradiation for race-induced multiple sclerosis. He is asking, are there any other parameters besides interleukin and cytokine that can we use for other coming studies?
So I'm not familiar with radiation, radiation to cure MS, is that, or to induce MS?
Yeah, lower dose irradiation to cure MS. Yeah.
So I'm not familiar with those. I have not read human studies using radiation. I don't think I've heard that they've tried that on humans. Yeah.
The same doctor is asking, are there other parameters that we can investigate to prove to reduce the effect of MS other than radiation or lower dose?
Other parameters in terms of radiation to reduce MS?
No, other effect than irradiation, not specially irradiation. Are there any other parameters that we can investigate to improve MS?
To improve MS. Okay, good question. So I think this is more drug therapy. I think a lot of them have focused on so far like modifying the immune system. I think that so far that's what has been effective and successful, is to control the inflammatory side of the MS. The neurodegenerative side of the MS question, I think, has not been as successful in terms of anything that will slow down the neurodegenerative part of the MS. Like all of our medications, disease-modifying therapies, really target the inflammation and the immune system, B cells, T cells. I think so far all the focus has been controlling the immune system, B cells, T cells, all the other inflammatory markers. Again, I think they're just going to try and target each one, but so far nothing really has been so successful about the neurodegenerative part of the MS. I don't know if other speakers have talked about more drug trials but like all of our disease-modifying therapies now really target immune modulation, immunosuppression, not so much the repair or the neurodegeneration side. So I think they're just going to go down the list and try and hit every inflammatory step in the inflammatory chain or the immune chain, but still you're just hitting the immune part, but not the neurodegenerative part.
We have another question from Dr. Ann. She's asking, how do you know whether fatigue is a side effect of a medication?
Good question. So that's a very good question. Always, when I see if that's a patient's complaint, I always take a look at what meds are you taking, because I think it's always going to be a factor. You could always see if there's a correlation, like, oh, they started taking a beta blocker, now I feel more fatigued. Well, that's the only change. It's difficult. It's hard to say we'll stop the beta blocker because they might need that for their cardiac and other issues. So that could be, in which case that could be difficult. But always go down their list, and like narcotics, actually they all make you fatigue, anticholinergics, all the anti-epileptics and baclofen, they all make you fatigue. And unfortunately, they won't let you stop their baclofen because it treats their other symptoms. But that could be difficult. That you could try lower your baclofen and see if you're less fatigued, but then now complaining of other symptoms.
I think that's all. Dr. Shahidi, do you see any other question?
No. No more question at this time. I think we will need to close the session. And thanks so much.
Thank you so much, Professor Sandoval Alexius, for his presence, his excellent presentation, for his kindness, and hope we will see you again.
Yes, thank you. Thank you for the
Thank
opportunity.
you so much. Have a good day.
Thank you.
Thank you, Professor Alexios. Thank you, everybody, for joining us for this webinar. And thanks for Merck Laboratory for supporting this program. Have a wonderful and great day.
Thank you so much.
Bye-bye.
Thank you.
Have a nice weekend.
Bye-bye.
Goodbye.
Thank you.
Yeah.